this is the overview I'll walk you through in the next 20 minutes. You need to know what are the types of insulin and their usages, roughly, because you are using this. The importance of correct insulin injection technique and why it is so. And then insulin during in-hospital management setting, insulin as also in outpatient setting, also very importantly, insulin in hyperglycemic emergencies. Of course, when you're using insulin, you know the patient might become hypoglycemic. So as a nurse, it is essential for you to recognize these kind of patients becoming hypoglycemic very early. So pearls of hypoglycemia and myths related to insulin in the community that you need to break. Okay, so since you are falling asleep, I thought that I should use this slide to draw your attention. So insulin discovery was a landmark in the medical care in 1921, which occurred. Actually, there's a big story behind that. I'm not going to go to the story. So these two gentlemen, Banting and Best, were awarded the Nobel Prize for discovery of insulin. But there's a big story that the correct discoverers were not given the Nobel Prize. So now imagine your great-grandparents who lived before 1921. If a person was diagnosed with type 1 diabetes means absolute insulin deficiency or receptor abnormalities. So these patients could not live without insulin. So there was no drug to survive. So if a baby or a child or adolescent was diagnosed with type 1 diabetes in those days, they are destined to die. But this discovery revolutionized medicine. Now you can see in these pictures from the internet, a girl who was just skin and bones, just by giving insulin, what a transformation that she has gone through. So this is a very important drug that has transformed medicine. Therefore, you need to know about that. Okay, so what are the indications for insulin? Okay, we know in type 1 diabetic patients, we have to use insulin. There's no other treatment, unlike type 2, where we have oral hypoglycemic drugs. And then even in type 2 patients, when they develop advanced disease, that the insulin secretion from the remaining islet cells of the pancreas becomes exhausted, and then you will have to resort to insulin. Also, when there is oral hypoglycemic failure, we resort to insulin. In case of gestation diabetes mellitus, insulin was to be the key treatment until some time, but now we use metformin as well. But it is largely used in GDM as well. Of course, in hyperglycemic emergencies and glycemic control in critically ill patients. You need to know a little bit about types of insulin because these are not interchangeable. For example, if a doctor has prescribed soluble insulin, you cannot give isophane insulin instead of that. If a doctor has prescribed mixed-dose insulin, you can't interchange that with a short-acting insulin. So I will go into details in further slides. So there are different types of insulin according to their action or the synthesis. Short-acting, intermediate ones like isophane insulin or NPH, long-acting ones which we ideally used in basal bolus insulin regimes such as glargine and detamir, but unfortunately these drugs are not available in the public sector but available in the private sector, and biphasic insulin which we all know, the pre-mixed or the mixed-dose insulin. Okay, so little bit of the dynamics of various types of insulin. I said about the short-acting one, and now we have the ultra-rapid acting ones as well. If you look at the yellow one, so the short-acting insulin, it lasts for about 4 to 6 hours, but it peaks within 1 hour. So that is very important. That's why we need to correlate the meal time with this insulin. That's why when you say that you're going to give insulin, that you ask the patient to, dish out the food and then inject the insulin within the next half an hour, the action will be enacted. So that is for a short-acting one. But if you see the red one, which I said the long-acting one, such as glargine, you don't get any peak. So it maintains a certain level of insulin without getting any peaks. So these peaks are associated with hypoglycemic episodes. So I will be talking a bit about basal bolus insulin regime because we need to emphasize on this. And please remember, those days we used to use actually the sliding scale. Sliding scale is no longer the standard of practice, right? It is becoming obsolete. So we are moving towards basal bolus insulin regime as much as possible. So as I said, the orange line indicates the basal insulin provided by the long-acting one and the boluses by the short-acting one, which is corresponding with the meal times. So as a nurse, I think all of you are aware about the correct insulin injection technique. This is extremely important because without that, the delivery mechanism of insulin is not going to happen. Right. So, yeah. So if I were to discuss the correct steps in in administering insulin, first of all, you need to draw the insulin, the correct amount properly. So I know in the hospital setting, you will be administering insulin, but at home, either the patient himself or herself or a caregiver will be giving insulin. And there are some inherent problems. For example, diabetic patient, advanced diabetes can cause diabetic retinopathy. And not only that, there are multiple causes of visual impairment in diabetic patients. So imagine your elderly patient drawing insulin, right, with poor vision. Sometimes they may not draw the correct amount because of their inherent problems, right? So you need to be vigilant about that. In addition to that, you need to know that once you draw the insulin, there will be certain degree of air bubbles remaining on the top of. So you need to tap it out to make sure that otherwise there will be 1 or 2 unit loss. You may not be given the correct amount of insulin as intended. Selection of the site is also very important. As you know in the diagram, we know the preferred sites are on the umbilicus, the anterolateral aspect of the thigh. Deltoids, of course, you as a healthcare worker, you can consider deltoid, but if the patient himself or herself is administering insulin, that is not very practical. I will explain why. Okay, right. This is because we know that in order to administer insulin subcutaneously and to prevent intramuscular injections, you need to pinch the skin fold correctly. I hope it's clearly visible in the second picture. Make sure that you don't pinch in such a way that it encompasses the muscle as well. So in the second picture, the muscle is also included. So you will be injecting to the muscle rather than the subcutaneous tissue. So that will give rise to adverse effects. Right. So this is very important. So when the patient has to inject himself, I'm talking about patients who are not on insulin pens. Now there are newer devices, right? So the patient will not be able to pinch himself or herself. So that's not going to work with the deltoid, right? And the other thing is, now once you have injected correctly, you have pinched the skin fold correctly, and then you are injecting 90 degrees, okay, to prevent intradermal injection. Slowly release the amount, and then withdrawing of the needle should not be hastily. It all should be done slowly within 5 to 10 seconds. If the 10 seconds is too long, at least 5 seconds. And then after that, the correct disposal of needles and sharps is also very important. Because sometimes our patients cannot afford, insulin pens, therefore they are on needles. So if they continue to use the same needle, it will become blunted and then pain occurs. Rotation of the site is very important. Why? To prevent these two complications. This slide shows lipoatrophy. I hope it is visible that you can see some lipoatrophy around the umbilicus. And this is lipohypertrophy. hypertrophy of the lipid layer. You can see a bump or an elevation. So all this occurs due to improper injection technique. Therefore, the delivery doesn't happen correctly. So a little bit about basal bolus insulin regime. It is the ideal, but only problem is we don't have the ideal long-acting, which is glargine in the public sector. Therefore, we might have to use an alternative, which is the next best, which is isophane, which is not an ideal long-acting one. So problem with isophane is you get nocturnal hypoglycemia because there is a small peak. And then the other thing is you are using two types of insulin, the short-acting one and the long-acting one, and injecting the patient 4 times. And therefore, monitoring also has to be done 4 times, especially if you're starting for the first time, 2 a.m. blood sugar to make sure the patient is not having early morning hypoglycemia. And the other important number you need to know is if you're treating a critically ill patient, especially I'm talking about medical patients, the target sugars are between 140 to 180, not very low, not very high. Of course, this is different from obstetric patients where stringent control is needed. Right. So if you can't use basal bolus regime, what are the other things that may be used? So you have pre-mixed insulin or mixed-starred insulin twice a day with an additional soluble insulin given to noon time to cover the lunch. And then pre-mixed insulin with correctional insulin regime. As I said, sliding scale is no longer recommended. This I will skip due to the interest of time. This will be determined by a doctor, the dose. Let's move on with some hyperglycemic emergencies. So a case history, 19-year-old boy diagnosed with type 1 diabetes, defaulted for 1 month, presented with polyuria, abdominal pain and shortness of breathing. On examination, he was dehydrated, had acidotic breathing with a tachycardia. On admission, the capillary blood sugar was high index, urine ketone bodies was 3+, and ABG shows metabolic acidosis. So diagnosis is straightforward, diabetic ketoacidosis. So all these criteria should be met to diagnose diabetic ketoacidosis. So how do we manage? Fluid resuscitation is paramount, and then soluble insulin infusion to bring down the sugar as well as to eradicate ketone bodies from the blood. So ideally, since this is an infusion, you have to use an infusion pump. But I know in resource poor settings, we might have to resort to burette sets, which is not ideal. Then CBS monitoring should be done hourly. Then the infusion should be continued until the urine is clear of ketone bodies, not until the sugar is normal. Sometimes when the sugar becomes less than 200, still if the ketone bodies are there, we need to continue the infusion with dextrose to prevent hypoglycemia. The other aspects are correcting potassium and looking for the cause and treating the cause and prevention of DVT because they are dehydrated. Then once the urine ketone bodies are completely disappeared, we revert to basal bolus insulin regime. We'll move on with another case history. 65-year-old patient, elderly patient, coming with confusion for 1 day, known to have diabetes. GCS is 13, severely dehydrated, but no features of infection. She has a high index sugar, ketone bodies are negative, no acidosis, sodium is low. So this is something opposite to DKA, what we call the newer term is HHS or hyperglycemic hyposmolar state. We used to call HONC earlier. The mainstay of management is correcting the volume depletion, and then we use insulin infusion, soluble insulin, here to bring down the sugar because there's no ketone bodies involved. So once the sugar is back to normal, then we can revert to basal bolus insulin. So if you are using insulin, you need to know about hypoglycemia because you are the first person to detect this. So why do you need to know about hypoglycemia? It is a life-threatening complication, common in type 1 diabetes, also in diabetes with organ failure like CKD and CLCD, the kidney disease. And if the patient is on insulin or sulfonylurea such as glibenclamide or glycoside or combinations, elderly patients with poor oral intake and critically ill patients. So how do you classify hypoglycemia? The number you need to know is 70. If the glucose level is less than 70, then the patient is hypoglycemic. There are deeper levels, I'm not going into that. So the most important thing is that you have to identify this patient rapidly and alert the doctor. So you have autonomic symptoms when the sugars are less than 70, like the patient, any patient on insulin, if the patient is drenched with sweat, always think about hypoglycemia. Patient is hypoglycemic until proven otherwise. Okay, so check the sugar and attend immediately. Sweating, palpitation, trembling, then they develop neuroglycopenic symptoms like confusion and irritability, then they develop seizures and go into coma. So we can't wait until that. So there's another caveat. Even though we expect the patient to develop these symptoms when the sugar is less than 70, some patients may not. That is due to impaired awareness of hypoglycemia when they develop diabetic autonomic neuropathy. Then it's going to be very tricky. So I know this slide is crowded, therefore I'll go in step by step how to manage hypoglycemia in this slide. So the key is you detect hypoglycemia. If the patient is conscious, then you try to correct orally with 15 to 20 grams of oral quick-acting carbohydrate, like 3 to 4 teaspoons of sugar dissolved in water, and then check the CBS in 10 minutes time. If it is more than 70 and the patient is clinically doing well, then don't forget to give a long-acting carbohydrate. We forget to do this. So what do I mean by long-acting carbohydrate? A slice of bread, some biscuits, or if the next meal is due, please give the meal. Otherwise, the patient will be becoming hypoglycemic again. If the patient does not recover, don't waste time. Revert to IV measures. So you can consider IV 10% dextrose 200 cc or 25% dextrose 75 or 15 minutes, and then assess clinically and repeat the sugars. Now, if the patient is unconscious, of course, you can't give oral. Then you have to admit the patient and you have to revert to IV correction. Lastly, I want to talk about some barriers for insulin usage, because there are lots of myths circulating in the society. There is a big psychological resistance for starting insulin among patients. Sometimes the patients think once you are on insulin, forever you have to be on insulin. And they think insulin is the last resort. When we start insulin, they think, okay, their sugar control is very bad and their diabetes is in the latter extreme. It is not so. And sometimes it so happens, we as doctors, sometimes, without our knowledge, use this as a punishment for patients. Sometimes we say, if your sugar is not under control next time, we will start insulin. So that psychologically affects the patient, okay? So always remember that when we are dealing with patients with insulin. In addition to that, if a patient on insulin develops hypoglycemia, that becomes a big stress. So once you get hypoglycemia, they are scared to continue insulin. And pain and needle phobia is a big challenge, right? And inconvenience, fear of weight gain are some of the other causes. So in summary, your role as a nursing officer when managing a patient with insulin is extremely essential, extremely important. And always train a patient and the caregiver who has been started on insulin while in the ward. For example, if you have started insulin for the first time and you are discharging the patients, always train the patient as well as the caregiver regarding the proper insulin injection technique and check whether it is correct. And then during the subsequent clinic visits, make sure that the patient follows these advices correctly, because often than not, when we do audits, the correction technique is not correct. Therefore, the patient's expected outcomes are not met. And make sure, grab the opportunity to empower the patients to eradicate myths related to insulin. Thank you.